Hello everyone, welcome to Raaonline. So we've come to the very beginning of our discussion on the MRCP Part 1 revision series. So what we've done is we've curated and put together the most important essential to know points from each system. So we've packaged them into 10 modules, and each module will be having one prep module with most of the salient high yield points. And then that will be followed up by a Q&A module where we'll be discussing a few questions, and then you can attempt them yourself after going through both the prep and the Q&A modules. So let's start out with respiratory system. This is the first installment of our MRCP Part 1 revision series. So it's very important to understand the basic physiology in the respiratory system. It's very important to know about the different volumes, which volumes make together which capacities. So we have 4 different volumes in the respiratory system, and they all put together and they make up 4 important capacities. So let's try to understand each of them. Now, the amount of breath that we take in during a normal inspiration or a normal expiration, that is called the tidal volume. Now, the tidal volume is usually 500 ml. This is a normal amount of air that is taken in during a normal inspiration, and hence it's going to be equal to the amount of air that's going to be expelled during a normal expiration. Now, the amount of air that we take in over and above the tidal volume during a forced inspiration, that makes up this inspiratory reserve volume, IRV. Now, this is going to be 3100 ml. This, the amount of air that we take in following over and beyond the tidal volume, what we take in during a forced inspiration. Similarly, over and beyond the tidal volume, the amount of air that is expelled during a forced expiration, that is called the expiratory reserve volume. That's also easy. Now, once a patient has expired the air following a forceful expiration, or rather expelled the air following a forceful expiration, what is left in the lung? The lungs are not completely collapsed, right? Whatever amount of air that is left behind, that is remaining, that is residual in the lung, that makes up the residual volume. This residual volume is going to be equal to the expiratory reserve volume. So these are the 4 important volumes that we need to remember. The tidal volume, normal inspiration and expiration. The inspiratory reserve volume is over and above the tidal volume during a forced inspiration. Expiratory reserve volume is over and above the tidal volume during a forced expiration. And whatever is left back in the lungs following a forced expiration, that is the residual volume. These are the 4 important volumes. Now, let's put them all together, and what we'll get something called the total lung capacity. Total lung capacity is nothing but the sum of all these volumes, as you can see from here. So you add this all together and you will know that the total lung capacity is going to be 6 liters. So this point. This is the point. So basically, at the end of a forced inspiration, the total amount of air that's going to be in the lung, that is this point, right? End of forced inspiration. That is the total lung capacity. That is going to be 6 liters. It is the sum of all these 4 important volumes. Now, what are the other capacities? There is something called the inspiratory capacity. Now, inspiratory capacity is the total amount of air that a person can take in during a forced inspiration. So that means it is tidal volume plus inspiratory reserve volume. So this is going to be 3600 ml. Now, so we've seen one capacity, we've completed yet another capacity. Now, third, there is something called the functional residual capacity. What is this functional residual capacity? It is the counterpart of the inspiratory capacity. So basically, this will contain the expiratory reserve volume and the residual volume. So this is the functional residual capacity. What does this mean? This means at the end of a tidal expiration, so at the end of a normal expiration, the amount of air that is going to remain in the lung is not only the residual volume but also the volume of air that is going to be expelled during a forced expiration, which is your expiratory reserve volume. So, FRC will be your expiratory reserve volume 1200 ml plus the residual volume 1200 ml. So, FRC functional residual capacity is going to be 2400 ml. The amount of air that is left behind in the lung at the end of a normal tidal expiration. This is the point of normal tidal expiration. Now, what is vital capacity? Vital capacity is basically a sum of three different volumes. What are they? Vital capacity is inspiratory reserve volume plus tidal volume plus expiratory reserve volume. Or you can say vital capacity is the inspiratory capacity plus the expiratory reserve volume, this whole thing. Or in another sense, you can say vital capacity is nothing but the total lung capacity minus the residual volume. This is the vital capacity. So, what is the total lung capacity? It is 6 liters. 6 liters minus 1.2 liters is 4.8 liters, 4800 ml. Even if you add all these three volumes together, no? So, IC is going to be 3.6 liters plus 1.2 liters, which is ERV, is going to give you 4.8 liters. So, what is this vital capacity? So, basically, after a forceful expiration, you expelled all the air. What is remaining is the residual volume. After that, when the patient takes in a forced deep inspiration, the amount of air that the patient is able to take in is this entire amount. That is the vital capacity. So, at the end of forced expiration, if a patient is asked to inspire forcefully, the amount of air that is going to enter the lung through that forceful inspiration is going to be all the way, it is going to start at residual volume and going to go all the way and reach the total lung capacity. That is why total lung capacity minus the residual volume gives you the vital capacity, or rather vital capacity plus the residual volume gives you the total lung capacity. Now, having understood this, let us quickly move on to the next important concept. Now, it's very important that we understand dead space. A lot of questions revolve around the dead space. So, what is the dead space? Now, we know that the space in the airways, right? Now, this space, it typically receives the air. There is ventilation happening, but is there gas exchange happening? Gas exchange is not happening. There is no diffusion. Therefore, this space is the dead space. Now, the tracheobronchial tree, all your airways, the larger airways which do not take part in gaseous exchange, they contribute the anatomical dead space. That is the dead space. Now, for instance, you see here, these are the airways where ventilation is happening, but gas exchange is not happening. Therefore, this contributes to the anatomical dead space. Now, you see this capillary here. This particular capillary is not being perfused. There is no pulmonary blood flow, whereas this capillary, there is pulmonary blood flow. It is a well perfused capillary with gaseous exchange taking place. Now, here, because there is no gas exchange taking place, ventilation is still happening, but perfusion is not happening. Therefore, there is no gas exchange. This is going to mimic the dead space, the anatomical dead space, and now this is going to contribute to the functional dead space. Now, anatomical dead space is constant. That is because of the presence of our larger airways. Now, alveoli which are not going to be perfused, they are going to give rise to the functional dead space. Now, what is this? The tidal volume into the respiratory rate gives the minute ventilation. Now, the alveolar ventilation, that is calculated by multiplying the respiratory rate not with the tidal volume but with the difference of tidal volume and the dead space, because the dead space is not participating in gas exchange. Therefore, alveolar minute volume is calculated by the difference between the tidal volume and the dead space, and that when multiplied by the respiratory rate, that is going to give rise to the alveolar minute ventilation. Now remember, the amount of surfactant required is directly proportional to the collapsing pressure. So that means higher the likelihood of the alveoli to collapse, higher amount of surfactant required to keep it open. Similarly, that is going to be inversely proportional to the size of the alveoli. What does that mean? That means larger alveoli, because they are going to be open easily, they will require lower surfactant and their collapsibility, their collapsing pressures will also be lower, whereas smaller alveoli, very tiny, easily collapsible. So they will require a larger amount of surfactant because the collapsing pressure will also be higher. This is another concept that is important to be kept in mind. Now quickly let's brush through the important concepts in VQ mismatch. So we've already touched a bit when I tried to explain the dead space. So V stands for ventilation and Q stands for perfusion. So usually there should not be a mismatch. V is equal to Q ideally. So when this happens, it is normal. So when Q is less, that means when perfusion is less, as we saw in the earlier image, that means there are a few alveoli which are not being well perfused. Now that is going to give rise to the dead space physiology. So remember, whenever there is a question which talks about a dead space physiology, that means the perfusion is low. When the perfusion is low, what happens to this VQ ratio? The denominator is low. Therefore, your ratio is going to increase. Remember that. Now, whenever a shunt physiology is being spoken about or discussed about in a question, then it means the opposite. There is perfusion that is happening, so Q is there, but the perfusion is happening to a non-ventilated lung. Therefore, what happens to the VQ ratio in the shunt physiology? The VQ ratio is going to be decreased. So, for example, take pulmonary embolism. In pulmonary embolism, what happens? There are going to be a few alveoli segment of the lung which is not going to be well perfused. So that is going to give rise to a dead space physiology. So whenever we say dead space, remember perfusion is impaired. Therefore, the VQ ratio will be described as having increased. On the other hand, take another pathology like collapse. In a lung collapse, or let's say in a segmental or a lobar collapse, what happens? There is no ventilation happening, but those areas are still being perfused well. So ventilation is low, but perfusion is intact. Therefore, what happens to the VQ ratio? VQ ratio is decreased. So this is called the shunt physiology. Why is it called the shunt physiology? So you all know, in congenital heart diseases with shunts, what happens? There is a mixing of the deoxygenated blood and the oxygenated blood. Similarly, here what happens? Because there is perfusion happening but no ventilation, this blood passes through without getting oxygenated. Therefore, this deoxygenated blood mixes with the other oxygenated blood and mimics a shunt. This is why this is called a shunt physiology. So remember, whenever the VQ ratio is described to have increased, you're dealing with a dead space physiology like pulmonary embolism. Whenever the VQ ratio is decreased, you're dealing with a shunt physiology like collapse. Whenever there's a shunt physiology, it's very difficult to increase the saturation, to increase the PaO2. Even if we increase the FiO2, the PaO2 doesn't respond as well as what we would see in a dead space physiology. Now, let's look at how we try to interpret PFT. This is again something that is very, very important, often asked in the MRCP Part 1 examinations. They give a permutation and combination of the PFT reports, and we will have to find out what it suggests of or which disease it represents. So, generally when you look at the PFT, two things that we should know. Either the PFT will reflect an obstructive pattern or it will reflect a restrictive pattern. So, obstructive patterns you are going to be seeing in diseases like bronchial asthma and COPD, whereas restrictive pattern you will be seeing them in diseases like interstitial lung disease or sarcoidosis, or even in obesity. These are the diseases where you have a restrictive pattern. So, these are the two broad patterns that you are trying to figure out when you read a PFT report. Now on the PFT, these are the values that are generally going to be described. The FEV1 and the PEFR. If that is markedly reduced and the FEV1 FVC ratio is also reduced and your flow volume loop, it shows a leftward shift with an expiratory scoop. Typically this is how the graph will look like. This kind of a expiratory scoop. So on top is the expiration. So there is this expiratory scoop and the inspiratory loop is normal, but there is this scooping in the expiratory flow volume loop. This picture with a reduced FEV1 FVC ratio, particularly FEV1 and PEFR reduced and the loop being shifted to the left with an expiratory scoop, this goes in favor of an obstructive pattern. So whenever you have an obstructive pattern, the next important thing to look at will be the FEV1 reversibility. So FEV1 reversibility following administration of a short-acting beta-2 agonist. If it is present, you are dealing with asthma. If it is absent and the post-bronchodilator FEV1 FVC is less than 0.7, then you are dealing with COPD. The FEV1 reversibility should be by more than 12% in case of asthma or by more than 200 ml. Now, when you are looking at a restrictive disease, remember R for R. So, usually the flow volume loop is going to be shifted to the right because there is restriction. Remember R for R again. So, there is reduction of all the lung volumes. So, all the lung volumes are reduced and hence what happens in restrictive also the FEV1 is decreased. But what happens, the reduction of FVC is much more because the denominator comes down, FEV1 FVC ratio will actually be increased. So, remember FEV1 FVC ratio will be reduced in obstructive whereas it will be increased in restrictive and the curve is shifted to the right in restrictive. Now, whenever you have a restrictive pattern, the next important question is, are we dealing with an intrinsic restrictive problem? For example, a parenchymal lung disease like interstitial lung disease, or are we dealing with extrinsic causes of restriction? Could be obesity, could be chest wall problems, could be neuromuscular diseases like myasthenia gravis. So, which of the two are we dealing with? For that, DLCO is a good indicator. Now, when you look at the DLCO, if the DLCO is reduced, that means there is a problem in the lung parenchyma. Therefore, you are looking at something like ILD, an intrinsic problem. If the DLCO is normal, that means there is no problem in the lung parenchyma. It is an extrinsic problem. So, it could be obesity, could be a chest wall problem, could be neuromuscular weakness like what is seen in myasthenia gravis, any of this. So, this is how you approach interpretation of PFT abnormalities, which is an often repeated aspect as far as the MRCP exams are concerned. So, let's try to understand these different flow volume loop abnormalities. The first diagram here, this is a normal flow volume loop. Remember two things. One is that the inspiration is actually reflected at the bottom and the expiration is reflected on top of the x-axis, and the x-axis here, although it goes from 0 ascending forwards, usually what happens, it is vice versa. You have 8 here and then 6 and then 4, 2. So, usually the x-axis is in the descending order, and that is where the leftward shift and rightward shift, which I was telling you about previously, that's where it comes into play. So, don't apply that on this particular graph because the x-axis is in the ascending order. So, this is the normal flow volume loop. Now, let's take the first image here. Here, there is a symmetrical reduction in the size of the flow volume loop. Both the inspiratory and the expiratory volumes and flow both have been reduced. So, all the volumes are reduced here and therefore, this is going to be a restrictive pattern. Now, you see this pattern here. Here, you see that there is the inspiratory flow volume loop is more or less normal. But what is strikingly abnormal is this expiratory scoop here. This expiratory scoop is typical of obstructive pattern. Now, restrictive pattern we discussed. Here, what are you able to see? Here, what you are able to see is there is a reduction not in the volumes, only in the flow. So, whenever there is a reduction in the flow, that means definitely there is an obstruction. So, this flow reduction is there symmetrically both during expiration as well as during inspiration. So, that means there is a fixed obstruction, fixed upper airway obstruction. Now let's focus our attention on the two diagrams below. Let's start with the left side diagram here. Here what are we able to see? The expiratory flow volume loop is almost normal, but the inspiratory volume is normal, but flow is decreased. So remember what I told you about flow correlating with obstruction. So whenever the flow is significantly decreased, that means there is an obstruction. Even here if you see, there is no significant difference in the volume. Volumes are more or less the same. This is the volume graph. But the flow is what is remarkably decreased. So here again the inspiratory flow is markedly decreased. So whenever there is a decrease in the inspiratory flow, remember I not for I. So that means there is an extrathoracic, variable extrathoracic obstruction. If it is fixed and if it's in the upper airway, then that reflects on both the curves, because that's not seen here. Here you have a variable extrathoracic obstruction. Whereas here if you see, the opposite holds true. Here you have a almost like an expiratory scoop, everything else is normal. So this is similar to our obstructive pattern. So all these diseases with the obstructive PFT like asthma, COPD, they all have variable intrathoracic obstruction, and that is what this is. So whenever there is a problem in the expiratory flow volume loop, then there is going to be an intrathoracic obstruction. So having understood this, let's look at DLCO and how we interpret it. This is again an important, often asked concept as far as the MRCP exams are concerned. What is DLCO? DLCO is the diffusion limited carbon monoxide. We are basically trying to use a gas which is entirely limited by diffusion, because it has a very high affinity to hemoglobin. The one thing that is going to affect the transfer of this gas is going to be diffusion. So therefore, the DLCO is going to be directly proportional to the alveolar surface area. To the we are using the DLCO to look at the alveolar capillary membrane characteristics, how good the diffusion is. So therefore, it's going to be directly proportional to the surface area, right? More the surface area, more the diffusion, and also proportional to the perfusion in the hemoglobin. The blood supply to the alveoli also has to be intact. There are two components to the alveolar capillary membrane, right? So from the alveolar end, the surface area has to be good. From the capillary end, it has to be, the capillary will have to be patent and perfusing the alveoli with normal amount of hemoglobin. So this is what is required for normal DLCO, a healthy, well-functioning open alveoli, ventilated alveoli, and the perfused alveoli. Perfusion should also be intact. Now, remember, the DLCO is going to be inversely proportional to the membrane thickness. So, thicker the alveolar capillary membrane, let's say there is an exudate, pneumonia, that's all going to decrease the DLCO, limit the diffusion. So, normal DLCO, what are the diseases where you have normal DLCO? Normal DLCO does not always imply that the individual is normal. DLCO can be normal in patients with extrinsic restriction. We remember our discussion on PFT abnormalities. So whenever there is a restrictive pattern, we look at the DLCO, because if DLCO is decreased, then it means there is an intrinsic restriction. If it is normal, it means there is an extrinsic restriction, either in the form of obesity or myasthenia gravis. So all these extrinsic restrictive diseases will have a normal DLCO. Remember that COPD and bronchial asthma, these obstructive diseases will also have a normal DLCO, because the problem is in the airway, not so much in the alveoli or in the capillary membrane. Therefore, these obstructive lung diseases also usually have a normal DLCO. Now, where will the DLCO be low? DLCO is low when the HB is low. So, in anemia, in instances of low perfusion, so like pulmonary embolism or pulmonary hypertension, and where the alveolar surface area is impaired, like ILD and emphysema, these are the places where DLCO is going to be low. So all the intrinsic restrictive diseases, anemia, pulmonary embolism and pulmonary hypertension, DLCO is going to be low. Now, some diseases can have high DLCO. What does that mean? That means, because this is a diffusion limited gas, that means the hemoglobin is very high. So either there is a bleed or there is polycythemia. So polycythemia, pulmonary hemorrhage can all, or instances like exercise which can increase the capillary perfusion, the alveolar capillary perfusion, can all increase the DLCO. Remember, sometimes in patients with an acute severe asthma, because of the RBC extravasation seen associated with the inflammation, that can give rise to an elevated DLCO. So elevated DLCO can be a component of acute severe asthma. So let's learn about the oxygen dissociation curve. Now this is again the something that's quite important. So remember, R for R, whenever a rightward shift of the oxygen hemoglobin dissociation curve has been described, rightward shift is seen in acidosis, in increased 2,3 DPG and in increased temperature. So these are the three instances which are going to cause a rightward shift, and R for R. That means rightward shift means release of oxygen from hemoglobin. For instance, you take this graph here, this red graph here. You are able to see that in this graph, when the oxygen hemoglobin saturation is 60%, this is at a partial pressure of oxygen of somewhere around, let's say, 35 millimeter of mercury. Now, let's say this patient has acidosis and this graph got shifted to the right. So, this is what a rightward shift would look like. So, here you are able to see the oxygen hemoglobin saturation is only going to be 20% at a partial pressure of 30 or 35 millimeter of mercury. So, this tells you that not all the hemoglobin is loaded with oxygen. A lot of oxygen has been released out. That is what this basically means. So, when the curve moves to the right, that means the hemoglobin has released a lot of oxygen, and therefore the oxyhemoglobin saturation for a given PaO2 will be much lesser because of the oxygen release. So, the hemoglobin binding, the affinity is much lower. That's what it means. Therefore, the opposite applies for left shift. Left shift is seen in alkalosis, decreased 2,3 DPG and decreased temperature. Left shift correlates with increased affinity. So, it's going to be very tightly bound. So, right shift basically release of oxygen, left shift there is more affinity. Right shift is seen in patients with acidosis where we are trying to improve the tissue oxygenation. Therefore, there is going to be more release. Leftward shift is something that's seen with high affinity hemoglobins or with carbon monoxide poisoning where there is going to be much less release. Now, clubbing. So, whenever you have a question that reads out to you that describes about a case, when there is a mention of clubbing as a clue, then this is a very useful tool to help us to narrow down the diagnosis. In respiratory system, there are a handful of diseases which can cause clubbing. One is asbestosis. Two, remember all the suppurative lung diseases, all the lung diseases with pus inside them could be bronchiectasis, could be cystic fibrosis, could be empyema, could be lung abscess, all these pus in the lung diseases, and finally idiopathic pulmonary fibrosis. So, these are the diseases where clubbing is present. So, asbestosis, idiopathic pulmonary fibrosis and all the pus in the lung diseases like cystic fibrosis, bronchiectasis, lung abscess, empyema. Now, most common organisms, this is again something that we should know. So, they may describe a case of COPD exacerbation and ask you which is the most common organism involved. For COPD exacerbation, it's going to be H. influenzae. For bronchiectasis, again, it's going to be H. influenzae. For cystic fibrosis, it is going to be Staph aureus, particularly in the younger age. And following Staph aureus, the second most common organism is only Pseudomonas. So, in your options, if Staph is there, it's going to be Staph. And finally, the most common organism causing CAP, community acquired pneumonia, is going to be Streptococcus pneumonia. So, remember, COPD exacerbations and bronchiectasis is H. influenzae, cystic fibrosis is Staph aureus, and community acquired pneumonia is Strep pneumonia. Now, community acquired pneumonia, it's very important to understand the different kinds of CAP syndromes because they can all be elaborately explained to you through different case scenarios, and you need to know what you're dealing with. So, what I'm going to do is I'm going to give you different patterns so that you're able to quickly get to an answer as you read through the question by recognizing the pattern involved. So, let us start off. So, when you're described a community acquired pneumonia and there is also a mention of either cold agglutinins or an idiopathic thrombocytopenic purpura or a Stevens-Johnson syndrome. So, this kind of a complication either in the form of a hemolytic anemia, cold agglutinin hemolytic anemia or ITP or Stevens-Johnson syndrome, or you can be described of a CAP as an epidemic amongst the army base population or in a subacute manner going on for beyond 3-4 weeks, then the organism is going to be mycoplasma. Now, when you are described of a pneumonia and there is also a mention of hyponatremia and also consistently a mention of a recent travel plus or minus diarrhea, then you're dealing with Legionnaires disease. When you're described a community-acquired pneumonia in an alcohol consumer and with or without an upper lobe cavity, then it's often Klebsiella that you're dealing with. When there is CAP and there is also a mention of HSV infection or a herpes labialis, then you're dealing with a Streptococcus pneumoniae. CAP in a post-flu patient. So when you're described about a case who's recently had flu, then went on to develop CAP, also having cavities, remember staph. So CAP and cavities, two important things. If it's an alcoholic, think of Klebsiella. If it is post-flu and cavity, think of Staph aureus. Now, Curve 65 based antibiotic is something again that you should all be thorough in, because this is again something that's often repeated. So, what is the Curve 65 score? Curve 65 is a score which is used to assess patients with community acquired pneumonia to quickly make a call on whether or not these patients require admission and whether or not these patients require IV antibiotics. So, these are the 5 parameters used: confusion, urea, a BUN more than 19 mg per deciliter, respiratory rate more than 30 breaths per minute, a BP less than 90/60, and age more than 65 years. So, this is what the Curve score 65 score stands for. Each is given a point, and that gives us a total of 5 points. Now, how do we stratify them? A score of 1 or less means the mortality is very, very low. The 30-day mortality is very low, and therefore all these patients are going to receive only OP care. A score of 2 tells us that the mortality is 9.2%, and therefore we will have to individualize, and most often these patients are going to require admission in the ward. A score of 3 or more means the patient is quite sick, mortality rates are high, and patient definitely requires admission, no second thoughts about it, often in the ICU. So, this is how you use the score to quickly assess and stratify your CAP patient. Now, how do you prescribe antibiotics based on this score? So, as I said earlier, you do a Curve 65 score, and if the score is 1 or less, that means you can manage with oral antibiotics in the outpatient setting itself. So, if it is the outpatient setting, then we are generally going to prefer oral amoxicillin or azithromycin. Now, if the score is 2, that means usually the patient is going to require admission, and we will have to think about a dual antibiotic therapy. So, usually you give both amoxicillin and a macrolide like azithromycin or clarithromycin. And finally, if the score is 3 or more, these patients are going to require definite admission, probably in the ICU with IV antibiotics. So, you start them on broad spectrum IV antibiotics like a beta-lactam inhibitor combination like amoxiclav, and add a macrolide like clarithromycin. Remember, if Legionella is suspected, strongly consider adding levofloxacin. So, scores of 4 and 5 definitely direct ICU admission. Now, PCP, this is again something, pneumocystis carinii pneumonia is something that is again often repeated in MRCP part 1 questions. So, remember that this is a unique pneumonia which occurs predominantly among the immunocompromised population. Patients present with a bilateral pneumonia. So, usually you will be described a case which talks about a patient who's having some immunocompromised condition like HIV, and then comes with bilateral pneumonia with low oxygen saturation and X-ray showing bilateral interstitial infiltrates, often with hypoxia, with elevated LDH. This is the typical picture of PCP. So, what is the best test for PCP? It's going to be induced sputum for a PCP antigen. So, a few important things as far as diagnosis is concerned among respiratory disorders. For bronchial asthma, what is the diagnostic tool? You look at the FEV1 reversibility. If that's more than 12%, it is bronchial asthma. When you're described a scenario of occupational asthma, typically where the patient develops symptoms only while going to work, and during the weekends or during holidays or vacations, the patient is completely symptom free, then what is the test that is going to be helpful? It is going to be serial PEFR testing, serial peak expiratory flow rate testing. Now, when you are dealing with cough variant asthma, one of the major ways to diagnose it itself is by a trial of inhaled steroids. If it responds, then it is probably cough variant asthma. Now, COPD, as I mentioned earlier, a post-bronchodilator FEV1 FVC ratio of less than 0.7 tells you the patient has COPD. Now, whenever you described a PFT abnormality or a patient with breathlessness, and they specifically tell you that the breathlessness is worse on lying down, and they mention specifically saying there is a fall in the FVC on the supine position, then they are talking about a diaphragmatic palsy, probably in the context of a Guillain-Barré syndrome. Now, when you say the patient has ARDS, usually these cases are described as patients who have acute severe dyspnea in hypoxemic type 1 respiratory failure, bilateral predominant lower zone chest infiltrates. And remember to say this is a non-cardiogenic pulmonary edema, therefore we need to make sure that the pulmonary capillary wedge pressure is less than 18 mm of mercury. Now, cystic fibrosis, sweat chloride test is what is going to help us in diagnosing cystic fibrosis, and sweat chloride should be more than 60 millimole per liter. In addition, CFTR mutation analysis is also going to help us in diagnosing cystic fibrosis. Now, hypersensory pneumonitis, three things are important. A, we'll have to establish exposure and have consistent serum precipitants which sort of parallel the exposure. Then the bar lymphocytosis has to be there, and histopathological confirmation is also required. So, these are the three things through which you diagnose hypersensory pneumonitis, but usually it's diagnosed based on the clinical history of symptoms, particularly acute hypersensory pneumonitis and all, where the patients will have symptoms only during the exposure. So, remember exposure and serum precipitants, biopsy and bar lymphocytosis. The bar lymphocytosis is something that is seen particularly in hypersensory pneumonitis. This is also seen in sarcoidosis. Now, ILD is something that is diagnosed by a restrictive pattern on the PFT and CT showing a characteristic honeycombing and ground glass opacity pattern. Obstructive sleep apnea is diagnosed based on a sleep study, also called polysomnography. So, either the AHI will have to be more than 15 in an asymptomatic patient, or the patient should have overt symptoms suggestive of obstructive sleep apnea in the form of excessive daytime sleepiness, increased snoring and all of that, with an AHI of more than 5 tells you the patient has obstructive sleep apnea. Now, pulmonary hypertension is diagnosed based on the pulmonary artery pressure, which is detected through a right heart catheterization. So, on right heart catheterization, if the mean pulmonary artery pressure is going to be more than 25 millimeters of mercury, that tells you there is pulmonary artery hypertension. Now, NICE guidelines in asthma is something that we should all be very thorough with while attempting MRCP part 1, because they can give you a question and the patient can be on any step and tell you that the patient is not responding to it. So, unless you know the next step, it's very difficult for you to find out what is the next line of appropriate management. So, this is how the stepping up pattern in asthma works as far as the NICE guidelines are concerned. So, what do? First off, you start off on a short acting beta 2 agonist. Then what you do? We add on a inhaled corticosteroid. So, initially the patient is going to be on a SABA SOS. Then you add an inhaled corticosteroid also to it, usually on an SOS basis. Then what happens? You add a leukotriene receptor antagonist. So, often in these questions, you would be described that the patient is already on salbutamol, you added budesonide and still the patient does not respond. The next step is not LABA, it is going to be LTRA. So, you will have to opt for Montelukast. Only if the patient is on salbutamol, budesonide and LTRA Montelukast. So, a SABA, inhaled corticosteroid and leukotriene receptor antagonist. Only beyond that point will you add LABA. And after adding LABA, it is pretty straightforward. Once the patient is on all these medications, patient is on LABA, inhaled corticosteroid and LTRA and a SABA SOS, and still patient continues to have symptoms, you will have to opt for MART. What is MART? Maintenance and reliever therapy. So, that is given as a fixed combination. So, you are going to start off with low dose inhaled corticosteroid, then step up to medium dose inhaled corticosteroid MART, and then high dose inhaled corticosteroid MART. So, this is very easy, very straightforward. You just need 2 minutes to remember the steps, and once you know the steps, you are good to go. You will be able to answer most of the questions in this pattern. So, let us say they are describing a patient who is on this step. So, a patient is on Montelukast, also on budesonide and salbutamol. Next, what do? You add a LABA. Patient is on all of this, then you add a MART. So, this is the gist of the COPD management. It's also good to know the basics of COPD management. Now, as we are able to see here, patients with COPD are divided into 4 groups. Now, these 4 groups are going to be based on 2 things. One, the quality of life and the dyspnea, the amount of symptoms that are present. So, based on the symptomatology and the restriction of activities, the group A and C will have lesser symptoms and not that much of restriction of activities. Group B and D are going to have significant symptoms and significant restriction of activities. Now, group A and B, remember, are going to have very few exacerbations, whereas group C and D are going to have a lot of exacerbation. So, to convey to you in a very simple format, you are looking at two things, symptoms and exacerbations. Low symptoms A and C, B and D high symptoms, A and B low exacerbations, C and D high exacerbations. So, remember, symptoms is the vertical y-axis and your exacerbations is the horizontal x-axis, and then you have these four groups. Now, in group A, what do you do? Group A is the group with less symptoms, less exacerbation. So, just adding a single bronchodilator would do. Could be LABA. So, group A, what happens? Group A has less symptoms and less exacerbations. So, adding a single bronchodilator would do. Now, what about group B? Group B also has less exacerbations but has a lot of symptoms. So, these patients require something which is longer acting for the symptom control. So, you are going to give LABA or LAMA, any one long acting bronchodilator. Now, let us look at group C. Now, group C, they have a lot of exacerbations but relatively few symptoms. So, all these patients need to be on LAMA. LAMA is long-acting muscarinic antagonist. LABA is long-acting beta-2 agonist. So, what about group D? Group D is the worst group. Very high symptoms, very high exacerbations. So, it's looking very grim. So, these patients are usually going to be on dual bronchodilator. They are going to be on LAMA and LABA, or we'll have to consider addition of inhaled corticosteroid. Now, inhaled corticosteroid is particularly important in three instances. So, one, when the patient has episodes of wheezing, so whenever there is a diagnostic uncertainty or you feel that there could be an asthma overlap. Two, when the patient has frequent exacerbations. And three, when the patient is going to have eosinophilia. So, in these three E's, you will have to consider inhaled corticosteroids for COPD. Otherwise, inhaled corticosteroids do not form the backbone of treatment the way it does in asthma. Remember that.